here so early in the morning on a rainy day. I'm impressed, actually. Everybody made it. So John is from Texas. He thinks that everybody is going to come and do something just because it's raining. He doesn't realize Californians actually stay home when it's raining. It's too much on the roads. I'm going to talk about how I treat CLL in 2017. One thing to just discuss in terms of how I would do it, along with John Pagel, who's going to come and discuss after me regarding the actual novel agents that have become approved. So I'm going to really discuss kind of how I think through the various information, various characteristics of the patient, the disease characteristics, in terms of a decision making, rather than going through an alphabet soup of various agents and bore you to death with the details of the various trials. And I think John will cover the actual agents and put it in context overall. Now, getting this to work. There we go. Okay. So I think, as it was highlighted, this has actually been an exciting few years in the world of CLL, with the advent of several novel agents in the past 3 or 4 years alone. I think this is a kind of a historical perspective of what's happened over the decades in CLL. In the 1960s, we really primarily had alkylating agents with minimal response rates. Over the years, purine nucleoside analogs came along where response rates, especially CRs, went up to 20-30% with single agent therapy, with a combination of purine nucleoside analogs and alkylators, certainly higher complete response rates and overall response rates. And in the era of chemoimmunotherapy like FCR and bendamustine rituximab, we could actually get high complete remission rates up to 70% and increase durability of these responses. The new era of B-cell receptor inhibitors and BCL2 inhibitors has come with similar results in terms of high response rates, although what is unique about these agents, at least in single agent, they tend not to produce too many complete remissions, and yet they are remarkably effective in producing durable disease control. And indeed, all of this has led to significant improvement in overall survival in our patients, as is demonstrated here, in comparison to the 1980s, where the prognosis of this was dismal, of this disease is dismal. Now you can see the curve actually is somewhere around 60% overall survival. The disease is still deadly in a reasonable number of patients, so a lot of patients still die of the disease. And I think some of this, by the way, I can't highlight that it's coming as a consequence of better supportive therapy, including antimicrobial therapy for management of patients. Now, the things that I consider in terms of treatment decision are kind of at least listed here. I'll talk very briefly in terms of indications for therapy, and I'll highlight quite a bit about the goals of therapy, whether really depending on the patient, the age, comorbidities of the patient, whether the goal is palliation. We are throwing around the terms minimal residual disease quite often, and the question still is there, whether there is some value to achieving complete responses and MRD negative status. I'll talk about a lot of the prognostic factors in terms of molecular profiling and how I use those in terms of making a decision, potential short-term and long-term side effects, and also I'll talk about performance status and duration and cost of therapy, which are significant. The indications for treatment haven't changed. Really, this is the IWCLL criteria from 2008. Still, the indication is really if the disease is active, that's when we would treat the patient if it's causing cytopenias or active symptoms. One thing that this always generates is whether for patients that, especially in the modern era of less toxic therapies, for patients that don't necessarily fit this criteria, is there some value to initiating therapy with the intent of abrogating the disease process and progression? And I think one thing I would highlight in that regard is take into account for, in the entire CLL population, about a third of patients actually will never require therapy for their disease. And indeed, despite all of the molecular markers that we have available, it's very hard to predict really what subcategory patients, aside from the 17p minus and perhaps the 11q minus disease, what other subcategories of patients would actually benefit from initiation of therapy before they reach a point where they're having symptoms and complications from therapy. Now, this is something that is an important food for thought, and it's relating to what's my goal for the patient, what's the patient's goal in terms of initiation of therapy. And then that's really what is the goal of the therapy? Is it really purely to palliate symptoms and control the disease, or really are we intending to put the disease in a remission and perhaps achieve an MRD negative status? Why is that relevant? Is in the era of chemoimmunotherapy with FCR and the bendamustine rituximab, it mattered a lot whether the patient achieved a CR, because for those patients that didn't achieve at least a good response, for example, in terms of the data for the FCR treated patients, if they didn't achieve at least a PR, they had a dismal prognosis. And for those patients that actually with FCR achieved an MRD negative status, they actually had excellent overall outcomes. And this is highlighted by the data from the German CLL study group here on the left-hand side. I don't know if I can point to something here, but on the left-hand side, you see the MRD level achieved with various FC versus FCR therapy. And on the right-hand side, you'll see no matter what. But, oh, I see, okay. So on the right-hand side here, you'll see really what I'm trying to highlight here really is fundamentally that the greater degree of disease control you have, the more improvement in progression-free survival. And this really applies to the era of chemoimmunotherapy. This is in contrast to what we see in the era of B-cell receptor signaling inhibitors, where as single agents, they have really high clinical response rates, and they can have durable disease remissions without achieving complete remission, and certainly not with any degree of MRD negativity. And indeed, there doesn't seem to be a clear correlation between the degree of response and the duration of response. In other words, patients can have PRs and yet have very long durational remissions. The other thing that is fundamentally important to recognize also is our criteria that we use to call somebody a PR as someone with a 10 by 10 centimeter nodal lesion going down to 7 by 7. That's a more, 51% reduction in disease burden. Most of us would consider that a still substantial burden of disease, and yet that patient can have very durable disease control even with residual substantial burden of disease. And in terms of supporting that concept, here is some data from the John Burr's group in the original ibrutinib study. As you can see, single agent, 63%, most of it PR, and yet pretty impressive short-term overall survival benefit. And this is update from Susan O'Brien, a phase 2 study that they did, whether you're looking in relapsed refractory patient or treatment naive patients. Again, on the right-hand side, you can see the curves, even for the relapsed refractory patients, are still after 5 years not reaching, there's no median survival achieved or a marker on the curve, and yet the disease control is really, at its best, is mostly a PR. In regards to FISH and its association and some of the molecular markers, this is probably one of the most important things that I use in terms of determining agents for therapy. And I think everybody in this audience is probably familiar with this original work from Donner et al. That was published now over, 17 years ago, regarding the progression and prognosis of patients with 17p and 11q, highlighted there in green and, what is that, purple? And there are a number of other prognostic markers that have been available, but what is fundamentally, and I think I stole this slide from Rick Furman, and you can see it looks like in academia we're very busy with all the various markers, but in reality, actually what is relevant is very few of these are usable from the average clinician in terms of making a decision. Things that are, and most of these are still traditional clinical markers or characteristics: stage, the age of the patient to response, and the durational response to the prior therapy. Perhaps in my practice, the thing that I depend on the most is interface FISH, looking for 11q and 17p. There's some value to the IGVH mutation and also certainly for p53 mutation. And why is that relevant? At least in terms of the 17p and the p53 mutated patients. excuse me, this category of patients have distinctly chemorefractory, essentially disease that is refractory to cytotoxic chemotherapy, whether you're using purine nucleoside analogs or in combination with alkylators or rituximab, so that's the survival there. And in regards to the 11q patients, there is some value if you're using an alkylator therapy. On the left-hand side, you see the patients that got an alkylator and had a disease characterized by 11q did better than those that had just a purine nucleoside analog. However, this is applicable to the patients that really primarily you're going to use alkylator therapy for. In the era of B-cell receptor therapies, at least in terms of overall response rate, this is data again from John Burt, impressively, in terms of achieving a response, it appears it doesn't make much of a difference whether you have a 17p, 11q. The only thing that you can see there on the curve is there clearly is some value to having an IGVH mutated disease, but otherwise, in terms of achieving a response, it doesn't make a difference what the disease characteristics are for the patient. One thing I would caution, there is indeed some value in terms of the 17p in terms of durability of responses. So indeed, the patients that have a 17p, as you can see on the left-hand side, they have a shorter progression-free survival even on B-cell receptor therapies. Again, this is on ibrutinib, and a trend toward a shorter overall survival. And again, in an update by Susan O'Brien, you can see at a 5-year mark, the 17p and 11q patients clearly are doing not as well as other subcategories of CLL. So even in the modern era, there is some value to checking and making decisions in terms of therapy, even on the B-cell receptor inhibitors as it pertains to these particular molecular characteristics. One other thing to take into account, and we have moved on, I think, from the era of chemotherapy, a lot of us in the academic arena, but there may be some value to still considering some cytotoxic chemotherapy, and that's one of the other things that I take into account, specifically in regards to the IGVH mutated category of patients. This is data from the CLL 300 study. They did a retrospective analysis of the patients at MD Anderson, looking at the patients that had been treated with FCR and looking at the subcategory of patients. And what I want to highlight in the curve actually is this area of the curve here, where you can see the progression-free survival and the overall survival is actually flattening out. And when they looked at the retrospective analysis of this and looked at IGVH mutation, impressively, you can see the mutated subcategory patients that 10 years into the follow-up, actually the curve is flattening out, which they're applying the word cure here, which is not an unreasonable. In other words, these patients are not relapsing and progressing and dying from their disease. So there may indeed be some value for this subcategory of patients that have IGVH mutation to consider FCR therapy, because they clearly have data-driven efficacy for FCR, especially in the younger patients that may be able to tolerate the therapy. 74% of the long-term survivors actually had mutated IGVH. So coming down the last few slides here in regards to some of the other considerations, I think again in regards to cytotoxic therapy, what drives us away from cytotoxic chemotherapy are the toxicities. I think everybody's aware, and this is data that I got from the randomized trial of FCR versus bendamustine. Really, I'm using the data to highlight the toxicity here. I think that all the experienced practitioners here are well aware of acute hematologic toxicity of any grade, 90% versus 66% in FCR and BR. Point being that both of them are still fairly toxic. They cause hematologic toxicity. Severe neutropenia, 81% when treated with FCR, 56% with BR. And the other thing is causes of death. We're afraid of secondary malignancies. 5% of patients on the FCR arm died of secondary malignancies. About 4%, only 4% died of CLL, including Richter's transformation, about 2.5% related to infectious complications. Similarly, what you can see in the BR arm. The point being that there is significant toxicity, and how this factors into decision is really primarily what ends up happening is the patients that are younger and don't have significant comorbidities should at least consider therapy with FCR or BR, but beyond this, I think all of us get afraid of cytotoxic therapy. And in terms of data looking for treatment-related myeloid malignancies, again, so I will highlight here significant secondary myeloid malignancies associated with fludarabine and fludarabine cyclophosphamide therapy. I think this is a little repetitive. The final thing, and I'll highlight here, is obviously to recognize CLL is a disease of older individuals, and most of these patients will have significant comorbidities. According to Sears data, at least 46% of patients will have one comorbidity at the time of diagnosis or therapy that will require you to factor in. And typically, at least for chemoimmunotherapy, tends to be renal dysfunction and cardiopulmonary disease. The Germans have adopted this go-go, slow-go, no-go categorization of patients. It's really somewhat similar to, it's a little funnier version of our ECOG way of evaluating patients and assessing whether the patient would be a reasonable candidate for at least, again, cytotoxic chemoimmunotherapy. And a more objective way of evaluating this is the Sears score, which is really a way to score the various comorbidities of the patient, the number of medications that the patient will require, and be able to at least have an objective way of evaluating the performance status rather than the general gestalt way of the ECOG or the slow-go, no-go approach. And the final few seconds I'll cover and kind of the segue into the therapy that will be available. So this is how I think about it in terms of frontline therapy for younger patients with no comorbidities. I still at least have a discussion regarding FCR versus BR. For patients that have comorbidities, the approved agents are a combination of obinutuzumab and chlorambucil, and certainly single-agent ibrutinib. And there are certainly people that are still using chlorambucil either as single agent or in combination with rituximab. All of these have FDA approval and the way that I've ordered them here is kind of how I consider them based on comorbidities. For relapse disease, ibrutinib still remains our favored agent. Venetoclax is now approved for disease characterized by 17p deletion, and I think John will cover this. And then the other options are idelalisib with rituximab, high-dose methylprednisolone, and again, chemoimmunotherapy is still an available option. In terms of the data available for FCR versus BR, this is a randomized study, and this debate will go on forever. The short of it is, in terms of selection of which cytotoxic chemotherapy agent, there's higher response rates with FCR, there's higher complete remission rates with FCR, as highlighted here, higher progression-free survival with FCR, and indeed, there is, if you look at the end of the curve here, there is a survival benefit with FCR in comparison to bendamustine rituximab. However, the treatment comes at a significant cost in terms of toxicity, both in terms of hospitalizations, severe infections, and as I highlighted and as I alluded to earlier, some toxic deaths. The other option in this setting, and this is really one of the strategies that has replaced traditional cytotoxic chemotherapy, largely is combination of obinutuzumab and chlorambucil. This was studied in a randomized trial of chlorambucil, obinutuzumab versus chlorambucil rituximab versus single agent chlorambucil. And again, what I'm highlighting here is higher response rate with the combination of Gazyva and chlorambucil, and even achieving MRD negativity in the blood and the bone marrow with a monoclonal antibody plus a chemotherapy that is really, I think, mostly considered a homeopathic medication. So pretty impressive responses with a combination. And indeed, this has the antibodies, namely obinutuzumab, has largely replaced other anti-CD20 monoclonal antibodies in the field of CLL. An improvement, as you can see, in progression-free survival in favor of the chlorambucil. So that's our favorite agent. And finally, regarding the B-cell receptor inhibitors, there are a number of them that are available. Sorry, I went through that very fast because I'm running out of time here. But in terms of the B-cell receptor inhibitors, the ones that I've highlighted there are the ones that have approval. But as you can see in the figure, there are a number of targets available, and there are indeed a number of agents in clinical trial at various phases of development that will probably make it to the market. They all do remarkably well. It's ibrutinib in front line. I think this data will be covered in just a little bit, but significant improvement in overall survival in comparison to chlorambucil. In the relapse setting, similar thing, high response rates, very few CRs. Here, most of the patients have PRs. Of the entire 63% overall response rate, all of it was all PRs, and pretty impressive durable response rates. Even at 5 years, you can see pretty flat curves, and in terms of overall survival, still not, the median is not reached at 5 years with single agent ibrutinib in the relapse setting, and certainly not also achieved in the treatment naive setting. One other agent that has come on the market is probably one of the most active agents is venetoclax, and this has its approval for patients with relapsed refractory disease with 17p deletion. This agent requires a dose ramp up for the first 5 weeks, so makes it a little bit arduous, and that's part of the factor to take into account in terms of older patients that may have some difficulty in terms of doing this, but nonetheless a very active agent with pretty impressive responses in excess of 80% and durable responses, even in the subcategory of patients with 17p. And the final slide is regarding idellicibratoxan, which still retains its approval. This is Zidelic, overall 81% response rate, and again, pretty impressive durable responses. So this is kind of some of the data in terms of what are the factors that I take into account to make a decision regarding therapy. I think Dr. Bagel will cover the specific agents, and then we can have a discussion as to,